Welcome to Pediatric Case Review. Today we'll discuss juvenile dermatomyositis, a rare inflammatory myopathy affecting children. This comprehensive lecture will cover diagnosis, management, and clinical pearls essential for pediatric practice. A 7-year-old girl presents with progressive muscle weakness for 2 months. She struggles to climb stairs and has a rash on her face and knuckles. What is the most common initial symptom in juvenile dermatomyositis? A. Muscle pain. B. Progressive proximal muscle weakness. C. Skin rash. D. Dysphagia. The correct answer is B. Progressive proximal muscle weakness. About 80 to 90% of children with juvenile dermatomyositis present with symmetric muscle weakness affecting shoulders and hips first. This typically manifests as difficulty climbing stairs, getting up from the floor, or raising arms above the head. An 8-year-old boy has a violaceous rash on his eyelids and reddish papules on his knuckles. What is the name of the pathognomonic skin finding on the knuckles? A. Malar rash. B. Gottron papules. C. Butterfly rash. D. Heliotrope eczema. The correct answer is B. Gottron papules. These are erythematous or violaceous papules over the knuckles, specifically the metacarpophalangeal and interphalangeal joints. They are pathognomonic for dermatomyositis and often accompanied by a heliotrope rash on the eyelids, which is a violaceous discoloration. A 6-year-old with suspected juvenile dermatomyositis is being examined. Which muscle group should be tested first to assess for characteristic weakness? A. Distal limb muscles. B. Proximal limb muscles. C. Facial muscles. D. Respiratory muscles. The correct answer is B. Proximal limb muscles. Juvenile dermatomyositis characteristically affects the shoulder and hip girdle muscles first and most severely. Important clinical assessments include observing the child climbing stairs, rising from the floor, or performing a sit-up. Manual muscle testing is important for quantifying strength. A 9-year-old presents with muscle weakness and skin changes. Besides Gottron papules, which other skin finding strongly supports juvenile dermatomyositis diagnosis? A. Heliotrope rash. B. Malar rash. C. Psoriasiform rash. D. Discoid lesions. The correct answer is A. Heliotrope rash. This is a purplish or violaceous discoloration of the eyelids, often with periorbital edema. It's named after the heliotrope flower due to its purple color. This finding, along with Gottron papules, is highly specific for dermatomyositis and helps distinguish it from other inflammatory conditions. What is the primary pathophysiological mechanism in juvenile dermatomyositis? A. T-cell-mediated cytotoxicity. B. Antibody-mediated cytotoxicity. C. Complement-mediated microangiopathy. D. Direct viral cytopathic effect. The correct answer is C. Complement-mediated microangiopathy. Juvenile dermatomyositis is characterized by immune complex deposition in blood vessels, leading to complement activation, endothelial damage, and capillary destruction. This process results in muscle ischemia and inflammation. Muscle biopsy typically shows parafascicular atrophy, reflecting this vascular pathology. A 5-year-old with suspected juvenile dermatomyositis needs laboratory testing. Which enzyme is most useful for diagnosis and monitoring disease activity? A. Alanine aminotransferase. B. Creatine kinase. C. Lactate dehydrogenase. D. Erythrocyte sedimentation rate. The correct answer is B. Creatine kinase. Creatine kinase is elevated in 80 to 90% of active juvenile dermatomyositis cases and correlates with disease activity and muscle inflammation. Other muscle enzymes like aspartate aminotransferase, alanine aminotransferase, lactate dehydrogenase, and aldolase may also be elevated but are less specific. A child with suspected juvenile dermatomyositis has normal muscle enzymes. Which investigation would be most helpful for confirming muscle inflammation? A. X-ray. B. Ultrasound. C. MRI. D. CT scan. The correct answer is C. MRI. Magnetic resonance imaging is the gold standard for detecting muscle inflammation in juvenile dermatomyositis, showing characteristic edema and inflammation patterns even when muscle enzymes are normal. T2 weighted images typically show high signal intensity in affected muscles. MRI can also guide muscle biopsy site selection for optimal diagnostic yield. According to the European League Against Rheumatism and American College of Rheumatology classification criteria for juvenile dermatomyositis, which finding is not included as a criterion? A. Gottron papules. B. Heliotrope rash. C. Proximal muscle weakness. D. Raynaud phenomenon. The correct answer is D. Raynaud phenomenon. While Raynaud's occurs in 15 to 20% of juvenile dermatomyositis patients, it is not part of the formal diagnostic criteria. The European League Against Rheumatism and American College of Rheumatology criteria include characteristic skin rashes, proximal muscle weakness, elevated muscle enzymes, and MRI findings as key diagnostic elements. A 7-year-old is newly diagnosed with juvenile dermatomyositis. What is the first-line treatment? A. Hydroxychloroquine monotherapy. B. Corticosteroids plus methotrexate. C. Cyclophosphamide. D. Biological therapy with rituximab. The correct answer is B. Corticosteroids plus methotrexate. The current standard of care for newly diagnosed juvenile dermatomyositis is high-dose corticosteroids, typically prednisone 1 to 2 milligrams per kilogram per day, with early addition of methotrexate. This combination has been shown to improve outcomes and reduce steroid-related toxicity compared to corticosteroid monotherapy. A patient with juvenile dermatomyositis is not responding to corticosteroids and methotrexate. What is the most appropriate next step? A. Increase methotrexate dose only. B. Add intravenous immunoglobulin. C. Switch to cyclophosphamide. D. Discontinue all treatment. The correct answer is B. Add intravenous immunoglobulin. For patients with juvenile dermatomyositis who are not responding adequately to corticosteroids and methotrexate, adding intravenous immunoglobulin at 1 to 2 grams per kilogram monthly has shown efficacy. Other options for refractory disease include cyclosporin, mycophenolate mofetil, and biological agents like rituximab. A child with juvenile dermatomyositis develops abdominal pain, vomiting, and guarding. What serious complication should be suspected? A. Pancreatitis. B. Intestinal vasculitis and perforation. C. Medication side effect. D. Acute appendicitis. The correct answer is B. Intestinal vasculitis and perforation. This is a life-threatening complication of juvenile dermatomyositis that requires urgent surgical intervention. It results from vasculopathy affecting the gastrointestinal tract. This complication is associated with poor prognosis and is more common in patients with severe disease or delayed treatment initiation. Early recognition and management is critical. A 12-year-old with juvenile dermatomyositis in remission for 2 years presents with hard nodules in subcutaneous tissue. What is the likely diagnosis? A. Lipodystrophy. B. Calcinosis. C. Nodular vasculitis. D. Foreign body granulomas. The correct answer is B. Calcinosis. This involves calcium deposits in skin, subcutaneous tissue, and muscles, occurring in 30 to 70% of juvenile dermatomyositis patients. It's associated with disease severity, disease duration, and delayed treatment initiation. Calcinosis can cause pain, functional limitation, and skin breakdown. It can develop even after the active inflammatory disease has resolved. Which condition is most strongly associated with juvenile dermatomyositis? A. Inflammatory bowel disease. B. Interstitial lung disease. C. Type 1 diabetes. D. Nephrotic syndrome. The correct answer is B. Interstitial lung disease. This occurs in 15 to 30% of juvenile dermatomyositis patients and is associated with specific autoantibodies, particularly anti-MDA5 and anti-synthetase antibodies. Interstitial lung disease may be asymptomatic in early stages, so pulmonary function testing and imaging are recommended for screening even in asymptomatic patients. Which factor is associated with better prognosis in juvenile dermatomyositis? A. Calcinosis at diagnosis. B. Early aggressive treatment. C. Presence of anti-MDA5 antibodies. D. Gastrointestinal vasculitis. The correct answer is B. Early aggressive treatment. Early diagnosis and aggressive treatment significantly improve prognosis in juvenile dermatomyositis by reducing the risk of complications like calcinosis and persistent disease. With modern treatment approaches, approximately 85% of patients achieve remission. Poor prognostic factors include delay in diagnosis, severe disease at onset, and certain antibody profiles. Thank you for watching this presentation on juvenile dermatomyositis. Remember that early diagnosis and prompt, aggressive treatment are key to improving outcomes. Please follow Pediatric Case Review for more informative presentations on pediatric conditions. If you have any questions, please leave them in the comments section below. We appreciate your support.